Okay, good afternoon, everyone. My name is Katie Cook. I am the Telehealth Project Manager with Adirondack Health Institute. Welcome to the September Telehealth Learning Collaborative. We haven't met since, I believe, May, so certainly a lot has happened in the telehealth and telemedicine space since that time. We decided not to meet in July. There was just a lot going on with COVID, and we wanted to kind of give everyone a little bit of a break. So we're reconvening today, and we have two fantastic speakers on deck today to bring to all of you, and then some updates from my end and from the North Country Telehealth Partnership. Of course, the North Country Telehealth Partnership is a joint effort between Fort Drum Regional Health Planning Organization and Adirondack Health Institute. So today with us, we have two fantastic speakers. We have Thomas Hallisey from Haney's and Dr. Ashish Atreya from RX Health and Mount Sinai. So Ashish is a healthcare executive with board certification in internal medicine, gastroenterology, and clinical informatics. As Chief Innovation Officer of Medicine, he leads the Sinai App Lab. That is one of the first collaborative hubs within an academic medical center to build and test disruptive mHealth technologies. He serves as the scientific founder for Mount Sinai spinoff, RX Health, that brings first enterprise-wide app curation, prescription, and engagement platforms to risk-sharing hospitals and payers in an affordable and scalable manner. He's going to be talking today about creating centers for excellence in digital health. And then after, we have Tom. Tom is from Haney's and has over 25 years experience leading healthcare IT. He has spent nearly 20 years as the CIO at several New York State and Washington, D.C. hospitals, including Cayuga Medical Center in Ithaca, Portland Regional Medical Center, and United Medical Center in Washington, D.C. Most recently, he was the Executive IT Advisor and CIO at Hartman Executive Advisors. Tom leads Haney's health IT efforts and works to guide health systems across New York State. As a friendly reminder, please make sure you're muted. We did mute participants upon entry, but sometimes, things happen. So just make sure you're muted or not having any background conversations. If you have any questions for our presenters, please place them into the Q&A or chat box. We will be monitoring both of those. I'm now going to turn it over to Ashish. You are muted.
Thank you very much. It's a pleasure to be here. And this is my second Haney's webinar, so super excited about the community that's being built here. I thought it would be very relevant to talk about not only telehealth, which many of you have experienced firsthand during the COVID time, but really what's in store in the future. And really think about creating center for excellence within our academic centers or within community practices in digital health. So just very brief thing, many of you know about Mount Sinai Health System. Founded in 1852, we are now 8 hospitals, 1 medical school, and 15 institutes. And what is relevant here is we have employee-based programs for 36,000 of our employees, which include 7,000 physicians and more than 2.5 million to 3 million patients who see us regularly. So a lot of technology follows the strategy. And for us, our strategy could not have been better said than these words, which our CEO said: if our beds are filled, it means we have failed. Really, we are looking very closely at value-based strategy and how we can bring hospital to home and really provide care where the patients are. And this is 4 years ago, so this was much more pre-COVID, when we really felt patients have to be in the community where we can provide the best care. But the challenge is no one has walked that path before. We do not know how to do that, how to provide the best care in the workplace, in the community, at homes. So I established the App Lab Innovation Center within Mount Sinai 7-8 years ago. And the goal was to really test different technologies, apps, analytics, and really aim to deliver awesome outcomes. We have now a partnership that cuts across 15 countries. A lot of research has come out of it, but now mostly a lot of transformation value has come out of it, which we are very proud of. We also have led to the formation of Node Health, That's a network of digital medicine, which I'll encourage all of you to be part of. It's free to join. Most of the academic societies are there, and that's the only network which supports digital transformation from beginning to end, and led by health system as its board members. And the mission of this board is to take the innovation which you are seeing, but really combine with evidence-based medicine so we can trust it and create the new science. And you can register for the upcoming conference, December 7 to 11. We will be taking much more scalable aspect of every different use case that organizations are using these days to really scale their digital footprint and how they do it so other health systems can learn from it as well. So I'll talk about our journey from innovation to transformation, right? Because a lot of the things are new when they're innovative, but really the value is harnessed when it is transformation, when it touches maximum number of providers, maximum number of patients. And how do you do that? So I like to share some of the blueprint that we have done. First, looking at the field of telehealth and digital medicine, we look at telehealth as just being one aspect of all the convergence of technologies that includes AI, apps, remote patient monitoring, Alexa bots, biomarkers, 3D printing, and all converge around the smartphone, which have amazing amount of processing power that we never felt was there before, and all the sensors and other things. So if you look at IoT connected devices, so we look at a wholesome view of digital medicine, which combines all those different disciplines which are mentioned here. But the challenge is it is very fragmented. Most of us are really boggled by this um, very fragmented digital health ecosystem. We cannot have all these companies just come into our cloud or our ecosystem because we can't manage all of them. And that creates confusion for providers, confusions for patients, but also creates confusion for IT. So a lot of our focus has been how do you take this fragmented digital medicine, which has enormous potential, not only in value-based healthcare, but also in fee for service, but really bring it in a very cohesive manner, like a digital daisy, which combines all the fields into a very good experience. Digital experience not only for patients, but also for our providers and IT ecosystem. So we envisioned that 4 years ago, and then we created a platform which connects with Epic in our case, but also connects with leading EHR system, where we are able to open up the window of digital health right within any EHR. So this is a view of that, where we are able to create customized digital toolkits for different specialties and service lines, from radiology to cardiology to gastroenterology to digital front door, which can be automatically prescribed using AI, or can be prescribed one-to-one, or can be prescribed to cohorts of patients. So for example, if you have an employee population of 15,000, within a day, you can actually prescribe them a mindfulness program. And that can reach to all through their email, through their text message, or through patient portal. And you can engage with them through that participation. So you can combine different tools like appointment scheduling, like bots for COVID screening, to wearable devices, all within one platform, and you can make it completely customizable for your own health system within a matter of weeks. So that journey started at Sinai and now has expanded beyond Sinai to around 10 health systems and two major national societies, including American College of Cardiology, American Gastroenterology Association. And that is the work within the Sinai work is done by our team. And then we have the team from RX Health, which is able to onboard, integrate the same platform for other health systems. So it has become a very good network for share and learning, not only academically what is possible, but actually learning from our example use cases. And if we do something today, tomorrow it can be replicated by any of the health systems which are part of the network, and vice versa as well. And our journeys, when it started 3.5 years ago, 4 years ago, our goal was to increase patient activation from 6% to something greater. And we were able to show if you prescribe any app, whether it is patient portal app or a mindfulness app or anything else, you are able to increase patient activation to up to 92%, because that patient do not have to search on an iOS store. They do not forget the name. It comes right on their smartphone. So I'm giving a flavor of what is possible today, but you may have some of those expertise already in your health system. So maybe some of those you can add on using your existing system, and it could be complete knowledge sharing of the use cases which can add maximum value. So very grateful for the partnership with Haney's to really respond to COVID through a virtual care platform. And now we are supporting around 7,000 telehealth visits a day. But not only video visits, which nearly every hospital has now access to, but the complete workflow where through a text message, the patient can be onboarded. We can get the symptoms of the patient. We can get them pre-visit check-in reminders right on their calendar appointment. We can give them a link to download the app, whether you're using Zoom or Cisco or Teledoc or American Well. Then it can give a post-appointment reminder. So all of those digital navigation, which takes the maximum amount of time and energy, and really that is lacking in most of the health systems, which have a capacity issue right now, with a lot of their employees not fully back. We are able to automate that process now using digital health as an extension of just pure video visits. But really, the biggest value health systems are going to get are not just from synchronous video visit, because they still require time and energy of a physician. It's just virtually instead of a in person. The maximum value all of our health systems are going to acquire is through digital front door, digital navigation, and remote monitoring. And health systems which are going to be able to do that in a very seamless manner will be actually creating a much more market share than anyone else. So I'm just laying some of the stuff that we have done, our partners have done in the COVID space, where you can actually bulk outreach to millions of patients at once. You can give them a triage bot right on their phone, which can work 24/7. So they can get prevention about COVID, but they can also get knowledge of how to manage COVID if they get. And if they do get any symptoms, COVID or otherwise, for chronic diseases, they can immediately link to your telehealth provider. And then they can be onboard on any monitoring program, which you can get reimbursed not only through remote patient monitoring codes, chronic care management codes, but you can also get it reimbursed through value-based care initiative, whether it is readmission reduction, bundles, or ACO. So just giving an example, we were able to launch a digital monitoring program right from EHR, where 1 million patients got a text using our program, and they were enrolled into Stop COVID NYC initiative. By outreach to 1 million people, we were able to enroll 55,000 people within few weeks. And we were able to, and that expanded to close to 1 million patients. And that we were following to find clusters within New York City. Now we have made it open that just through a text-based program, any patient, any member can enroll into any kind of clinical trial or any kind of clinical management study. We extended the framework during July 1st for a Doctor's Day. So any healthcare employee can just text and get onboarded on a mindfulness program, which was crafted in partnership with a leading mindfulness expert. So these are the ways you can scale benefits to all your ACO population, to all your employee population at either zero cost or a nominal cost, because the programs are already built to be shared with the community. We are now extending this entire framework of software-based remote monitoring and SMS-based remote monitoring to include device-based remote patient monitoring, but not only just devices which can bring in the data, but it also includes a 4G hub. So patients do not have to actually create any login. They do not have to check up and integrate with their Wi-Fi. They do not have to sync with any app. As soon as you plug in the 4G network into your home and you take a blood pressure or you take a weight, the data comes back readily. And you can then, as a hospital, create reimbursement of $100 to $160 per patient per month, especially if it's a Medicare patient, or you can create some incentives for people who are in at-risk population. Many commercial payer population and many state Medicaid programs are also now reimbursing through RPM. In many hospitals, when they're not Medicare patients, you may still be able to reimburse for something close to chronic care management with many of our commercial partners. So the cost to now onboard is 1/10 the cost which we had traditionally seen till last year. So for software-based remote monitoring programs are $1 to $5 per patient per month, and hardware-based remote patient monitoring can be from $10 to $30 per month. And that is something that you can bring it to majority of your population now. And really, if you combine those remote patient monitoring with digital navigation program, with software programs that allow behavioral change, you can yield better outcomes. And not only you're monitoring those patients, but actually getting patients are getting much more better, which allows you to decrease your readmission rate. We did that for heart failure and equipped the patients, leaving not only with a blood pressure device when they were discharged, but also a digital navigation program, which you see on the smartphone in a text message. We taught them how to do a blood pressure and how to eat healthy. And we were able to show 50% readmission rate reduction compared to a national average. So in the interest of time, I'll just fold up all the use cases, whether they are from readmission reduction to actually filling the appointments for colonoscopies, procedures, surgeries, and radiology during the COVID time, to supporting the bundle replacement program, to clinical trial recruitment, to COVID-based pathways. We are now running majority of these use cases, and each use case takes only a few weeks to add on and creates an exponential ROI for us. So I would urge many of you who are physician leaders, are leaders in IT or operations or executives, to really look at creating exponential value from health IT, not just from telemedicine, but really using the entire breadth and scope of digital medicine and converting IT into revenue center, not only for fee for service by increasing your referrals, digital monitoring, and digital front door, but also for value-based healthcare for hospital at home, for research, and also for employee health. So one of our focus area is to really partner with many of your health systems and IPAs or community hospitals to really create Center for Excellence Network in partnership with Haney's and really create value, which not only starts with innovation, but really ends with transformation. And to be able to do that, we really feel collaboration is the key. And I really want to thank Haney's for being a very good collaboration unit, bringing all of us together so we can transform our health system and create value across the different service lines. Thank you very much.
Excellent, thank you. It's funny because I was just reading an article actually this morning about some of the work that the Mayo Clinic is doing in terms of data and algorithms and really bringing this new digital front door to their patients. I mean, it's really transforming the way that healthcare is being delivered. And like your one slide said, digital medicine is, with digital crossed out, just medicine. So it's nice to see that there's a lot of work being done in this space. If anybody has questions, feel free to put them in the Q&A box or chat box. We're monitoring both. For now, I'm going to switch it over to Tom. And Tom, you're now presenter, so you're welcome to share your screen.
Okay, let's see if I get this right.
Yep, you're good.
Perfect.
Seamless.
Okay, thank you. Thank you for having me. As mentioned, I'm Tom Hallisey with Haney's, and thank you, Ashish, for that great presentation and the shout out to Haney's as well. It's great to collaborate with folks in New York, like Mount Sinai and all the great work Dr. Atreja is doing there. Really cutting edge stuff to bring all these different technologies together into something useful for a useful both provider and patient experience, as you mentioned. So I wanted to come at all of this from a slightly different angle and look at what we were just discussing and all the great digital tools and technologies and capabilities, and look at them in relation to the healthcare marketplace and competition as we move forward. So we've all heard the stories about the increase in telehealth work. We've all lived it. We've seen it happen. We know it works. And we've seen the 1,500% increase. Actually, no, 15,000, 150 times as much telehealth work being done in the Northeast region, I think more in New York than there was a year ago. And this chart just shows is a McKinsey report that shows that their estimate is that there will be $200 billion in telehealth digital healthcare services in 2020 alone, and then break down how they got to that number based on the percentages from each area. And I bring this up, in my case, not to toot our horn, which is great to toot because there's a lot of great work that's been done to get us there, but also to point out that reports like this are made for investors and startups and big tech to look at and see those dollars and think, I want to be in that market if they weren't already. And fact is, we know most of them were already. And so what we have now, as we move into this new digital frontier, you may not say it's new, but having everyone using it is new since the crisis really began in March. And so that players such as payers, pharmacy and retail, big tech, and telehealth dedicated providers that were already moving into healthcare, that were already looking to take their particular expertise into actually providing healthcare, are really all now looking at the digital front door, as Ashish just mentioned it, and you often hear. Everyone's looking to control healthcare delivery by controlling that digital front door. And what they're looking to do is compete on digital delivery with engagement apps and platforms, well beyond telehealth platforms, as was just noted with RX Health, to really a whole digital scope of services that puts the user first. A great example was just in the past 2 weeks, Walgreens, they have what they call the Walgreens Boot Alliance, and they announced an expansion of their services with a strategic partnership with Microsoft and Adobe to launch what they call a world-class digital and consumer platform to deliver personalized healthcare. That's pretty telling right there. It's a lot of words they threw into that, but they're looking at the digital front door, a world-class digital experience for healthcare. Now, they can't help themselves and throw in at the end of that sentence and shopping offerings, because that's what they are first and foremost, and they own thousands of stores. But I point that out because that's an important lesson for us as well, that they're clinging to what they've had before. We need to be careful not to overdo that ourselves, that this is a new world, this is a new means of engaging our consumers, and in every other industry that's expected digitally as well as in person when necessary, but that the two are integrated. That I don't make special exceptions for one versus the other in any other industry necessarily. They function together. And a big key group there is big tech. We're hearing about them endlessly with their forays into healthcare, and we hear endlessly also about their data. But I'm not here to talk about that, because I think possibly more important than all the data they already collect and their ability to use data effectively is that they're all based on user experience. Their lifeblood, how they were created, their very DNA is user-focused. And that's, and I'll get into a little more of that in a moment, but that has not been healthcare's focus to date. And that's where they see.
Katie, can you hear me?
Yes.
I just want to make sure everyone's line is muted. We did set it up so everyone's muted on entry, but I can hear somebody typing quite loudly. So please double check on your side that you're muted. Sorry about that, Tom. Go ahead.
Oh, no problem. Definitely wasn't me. I can't type and talk at the same time. I know some can. So big tech. So we've all heard about that, but my point is that the real key, I think, for us to consider there is that they are experts in user experience. And I've included in here as well the telehealth dedicated providers, the national telehealth providers, simply because they are providers. And as we move to a virtual world, as healthcare is transformed digitally, like so many other industries, we have to remember that they quickly become competitors. And to highlight this, it was American Well that is partnering with makers of smart TVs in your home so that they can have their app directly in potential patients' homes. Obviously, this is an immediate threat to cut out the local community provider that they may previously have partnered with if the patient now has direct access to them in the home. And the same goes for all of those providers who are now contracting directly with payers. And the payers are frequently looking to guide everyone to their particular platform, which often works around rather than with, unfortunately, the local community and the community providers. So I'll get to some positive aspects as I hit all this doom and gloom and fear to begin with. But I first wanted to point out, and I think Ashish did a better job of this, so I won't dig too deep into it, but that there's a virtual care spectrum. And this graphic is hardly meant to be comprehensive. In fact, everything in here is specific tools that were in use in New York State at health systems during this crisis. So I chose the particular boxes for that reason because this is all real world. In fact, most of these boxes were touched on right with RxHealth's COVID-19 platform, where you could reach out and with an initial engagement and assessment tool that could guide you to a chatbot for more information, to download educational information, and even collect data based on surveys, assessments, or temperature, and then move to virtual visit, other types of interaction with providers into the hospital, and then on to follow-up care. So we're looking at this whole picture of digital, and as I'll get into, now it's all about, we did a lot of this, we did many pieces of this, we found much of it very effective. Now what? And what do we do with it to compete with all those groups I just noted? And well, to compete digitally is generally based on consistent experience that's certain, it's consistently the same every time. I'm certain it will work wherever I am, and I trust the provider of that service. So, the most obvious case is, for instance, with Uber now, we always hear about how drastically they've changed transportation, at least up until this year. We'll see where it goes from here. It gives everybody else a little time, but it's consistent. I'm certain to get a ride. It works the same way every time, everywhere, and for the most part, I trust that, first of all, the amount they say it will cost, that they'll handle all the other aspects behind the scenes. I don't have to deal with any of that, and everything's integrated together. So I have a universal app that does it all. And we clearly don't have that in healthcare at this moment. We don't have a winner. There is no app out there that works in all geographies, with all platforms, handles all the behind the scenes financial aspects to your care. We're nowhere near that. And that's good and bad. As I'll point out in a moment, that's a huge opportunity for us, not necessarily a bad thing. And as we look at what will come in the future of digital care, it's important to point out little aspects like I've noticed and seen an announcement that Google in searches has said that they will begin to, they aren't doing it in New York anywhere yet, not that I've seen, but will begin to show virtual care options. So if I go and search for healthcare in a given area, I'll also get virtual care options, which sounds pretty benign until you think that this is a platform that sells advertisement, and suddenly national providers who can provide virtual care anywhere are competing with me for my consumer right here in New York. So just a couple quick statistics. I won't get into too much of this. There's obviously plenty of stats on what's happened this year. But I just want to point out that 76% of consumers surveyed by this McKinsey report, same report as the statistics I just showed, say that they're interested in using telehealth moving forward, which is a whole lot more than it was previously. And the same goes for the provider end. As we've increased telehealth 150-fold, obviously somebody was providing that care, and that was our providers, who I would point out in a survey by Deloitte just at the beginning of 2020, it was 90% of providers said that we really needed more education and integrating of these new digital technologies into our operation before we expand the services. Obviously, we did it anyway because we had to, but that's an important point moving forward, and it's an important point that there was some resistance. And I think the key stat here is that 64% report that they're more comfortable using telehealth now. I like to think that the other 1/3 of providers were already comfortable because most have had to use it at this point. So before I get into the details of post-COVID-19 digital care and some things we need to consider, I just wanted to throw out there the question, and I'm not looking, we're muted, not looking for feedback, but I've done this with large groups a couple of times this year, asked telehealth professionals and caregivers, physician leaders, have you personally downloaded your medical record to a mobile device? And the percentage that have is pretty low. But then I get to, have you downloaded, has the file you've downloaded, does it contain information from more than one provider? Because let's face it, if we're getting care, we get care from more than one place, more often than not. And the statistics nationally are minuscule for that, and even for those who provide this care, it's incredibly small. And so I point that out because it's a huge opportunity. This isn't happening yet. There isn't somebody who's figured out how to integrate the digital aspect to care into a perfect user experience. So it's wide open, but it's time to consider how our strategy will fit that in, how we will get all of those we used to provide services to back into our operations to provide them that care. And one important key here is that it was a recent survey that showed that, and I'm blanking on who ran that survey. I don't seem to have it in my notes, but if anybody'd like to see it, I'll find it and send it out. But it showed that the most trusted source for information on COVID-19 was local healthcare resources. So there's a huge opportunity. People trust their local healthcare more than anything else. That's who they want to hear from. And as I mentioned, the digital care market is wide open. There are no comprehensive tools that do everything and connect everyone to how they want to manage their care and get their care. We've seen the consumer willingness to use telehealth go up, the provider reluctance somewhat overcome. In fact, I think I harkened back to the days of installing an EMR for the first time and trying to get everybody on what we used to call computerized physician order entry, and the reluctance that existed for that. And there was some feeling that there was going to be a lot of that moving into telehealth, and much of it we've overcome now. As I mentioned, we can't rest on that. We still have to look at the issues with integrating that in. And as Ashish mentioned, the user experience from the provider standpoint and how they will manage this. But also, just this year, there was a survey done by the Harris Poll, national survey, where more than 2/3 of consumers said every step of the healthcare process is a chore. Most said they don't know how much a treatment costs or a visit costs, until months later. And nearly everyone said they wanted shopping for healthcare to be as easy as shopping for other services. And more than half then stated that they have waited on care, avoided seeking care immediately because of this. So there's a huge opportunity out there, and there are folks beginning to look at it and take advantage of that. A couple of places I want to mention, because we just heard, was it Cleveland Clinic just mentioned the partnership, or the Mayo? But in both cases, the Mayo and the Cleveland Clinics are looking to go national, are looking to provide their telehealth services, their digital care nationally. And they can be seen as a partner or a competitor, but we need to look at those types of services, learn from them, and decide whether they're a competitor or a partner, because they're out there. The Mayo Clinic is providing hospital at home nationally. Cleveland Clinic has partnered with American Well to provide their services, and Cleveland Clinic physicians nationally. So as a quick recap, it's a somewhat wide open market that everybody's beginning to dip into, which gives us a great opportunity. And the real key now is the integration. And I use that word as broadly as possible, because I'm talking about operational integration. I'm talking about an integrated user experience. I'm talking, sure, about integrating into an EMR. But I'm talking as well about integration with a digital platform like you just heard from Ashish at RX Health. If I have all of these digital tools, how do I weave them together into that user experience? Not just the consumer, but the provider. How does the provider even know what tools are out there? How does he or she prescribe them to the correct patient? And I also would feel negligent if I didn't point out the technical aspects here, and I put FHIR, for those who don't know, that's the Fast Healthcare Interoperability Resources. But the FHIR is an application programming interface that is now the standard as dictated by HHS and the new federal regulations, that all payers, providers, EMR vendors, health information exchanges, the New York State Shiny, your regional health information exchange, Healthy Connections, HealthX, whoever it may be, all must meet those standards. We'll all be using this FHIR API standard. And I point it out here because that can be the key tool now that can create this digital platform, this single user experience. We now have the capability without hundreds of separate interfaces that we have to sit and write, that simply wasn't practical and wasn't going to happen, to integrate all these different aspects in, whether it's the telehealth care, the remote patient monitoring Ashish just mentioned, the cost of care and all those billing aspects, your claims info and coverage from your payer. All this information now theoretically is accessible from this same standard and these same tools. This is brand new. Well, the technology is brand new, but the regulation that goes into effect November 2nd is new. And the new marketplace and world it will create is just beginning to be seen. But that's why we've got the wide open market. And that's why we have our chance now to act. And so that's my main theme here, is that we can act now. It sounds like there's a lot of competition and it's a frightening new world, but it's wide open and we are the trusted sources. So I will end there and happy to answer any questions.
Thank you very much, Tom. No questions have come through yet, so we'll just monitor that. Thank you both for your presentations, and the consistent theme between the two of them being where the future of digital healthcare is going. So it'll be interesting to see with that new regulation on November 2nd, how that really changes that landscape. So I am going to make myself a presenter, I want to share a few items with all of you, some general updates. Bear with me 1 second. Okay, so hopefully you see on my screen a shortened agenda of our upcoming telehealth conference and AHI Leadership Summit. And so starting next Monday, we will be doing a 2-week virtual learning symposium. This is replacing our normal in-person telehealth conference that happens every year, but with everything going on, we felt it was in our best interest to offer a virtual option. This is a no-cost event, and rather than having 2 or 3 days of 8-hour sessions and conference days and sitting in front of a computer, we felt it made more sense to do 2 1-hour sessions per day. So all of these links are clickable, and I will include this shortened agenda in the meeting notes, but you can also go to our website, which is ahihealth.org/2020 conferences to register. So we have 5 days in a row of some really fantastic telehealth speakers. You'll notice today that we did not do any state agency updates as we normally do on this learning collaborative. Reason being that on Wednesday, September 23rd from 2 to 4 p.m., we will be doing a New York State telehealth update panel. The speakers listed on this PDF document have since been updated. We, in addition to Amy Smith from OMH, have Christopher Smith joining. We have from the Department of Health Office of Health Insurance Programs, we have Ron Bass and Kendra Muckle, as well as Megan Procrum from DOH, and of course, Carmelita Cruz from OASAS, and they will be giving their respective agency updates and the future of telehealth regulations, especially as it relates to COVID. The AHI Leadership Summit is the following week, and I'm not going to pull that agenda up, but those are more whole person care centered updates. One update I wanted to provide today was just some updates from the federal level. So I'll be brief with this. So since we've last met, there certainly continues to be changes. Most notably, the public health emergency was renewed on a federal level on July 25th, and that is currently set to end on October 22nd. Additionally, at the state level, the governor did extend Executive Order 202 that extends the state of emergency in New York to October 4th. So any of the OMH or OASAS or DOH changes to regulation or billing will continue through October 4th. So on August 3rd, CMS, as they do annually, released their proposed physician fee schedule for 2021. And what was notably different this year was a Category 3 list of codes. Typically, they fall into Category 1 or 2. So CMS released this list of services that they're seeking comment on to decide whether they should be added on a permanent or temporary basis or not. Additionally, on August 3rd, the executive order that was released included information on the innovative payment model to enable rural healthcare transformation, which is known as the CHART model. I'm sure a lot of you are familiar with or have seen some information on the CHART model. They're also looking for a development and implementation of a strategy to improve physical and communications infrastructure in rural America, among a few other things. So a quick summary of some of the proposed codes. So Category 3 codes are new. In order for these codes to become permanent, they would ultimately need to meet the qualifications of a Category 1 or 2 code. However, allowing them to be provisionally allowed until the end of this year, in which the public health emergency ends, would at least give CMS enough time to thoroughly assess the code's qualifications to be allowed permanently. So the top table here, these are services that CMS is proposing for permanent addition to the Medicare telehealth services list. And then the bottom table are some of those Category 3 codes, which are temporary until the end of the year, unless CMS deems otherwise. And this is this table is telehealth services that CMS is not proposing to add to the Medicare telehealth services list, but they are seeking comment on whether or not they should be permanent. Proposed federal legislation. So there are currently, I believe, 27 federal bills related to telehealth that are in different stages or committees at this point. There's 8 at the state level. So some of these bills are focusing on similar themes here, really trying to make many of the regulatory flexibilities granted to all of us permanent. So a great example is the Connect for Health Act. This act is trying to eliminate the geographic restrictions in the Medicare program as it relates to telehealth. If you remember, prior to COVID, a patient could only, a provider could only bill for a patient's telehealth services under Medicare if they were located in a rural health professional shortage area or a non-metropolitan statistical area. So this bill is looking to eliminate those restrictions and allow the home to be an originating site for mental telehealth services. This bill also has another important component for federally qualified health centers and rural health clinics, and is looking to remove the geographic restrictions for those facility types, as well as, and most importantly, allowing them to furnish telehealth services as a distant site on a permanent basis. Those 2 components of the Connect for Health Act would require congressional action and will be a bit tougher to achieve, but there seems to be a lot of interest in this bill. Here are a few more proposed federal bills that are really trying to make permanent many of the regulatory flexibilities granted. Another important one on here, for example, Senate Bill 3999, looking to continue eligibility of care for the expanded list of non-physician providers. So prior to COVID, the list of eligible Medicare telehealth providers was limited. It has since been expanded to include some different therapist types, and this bill is looking to continue to allow that. And then you'll see here, both Senate Bill 3999 and 4103 are trying to get Medicare to cover audio-only telehealth services, aka telephonic. Now in New York State, Senate Bill 8416 was signed into law by the governor, and that was in the June or July timeframe. I'm not quite sure of the date, but that was signed into law and adds telephonic services to the state's definition of telehealth and telemedicine, which is an exciting win. Not entirely certain yet how that will be rolled out by the respective agencies, so we have yet to see. Again, this slide, I haven't updated it yet, but the state disaster emergency has been renewed through October 4th, not September 4th. A couple of proposed bills in New York State. Some of these have been around for a while. Some of them are newer. There are a number of telehealth payment parity bills that have been in limbo for several years now. But more recently, some of the bills on this slide include Senate Bill 8609. This is important in the substance use community. This would authorize peer recovery advocate telehealth services for reimbursement. OASAS did allow SERPAs to provide telehealth services during the state of disaster emergency. So this bill is looking to make that a permanent state. Additionally, we have a bill here, the second one, Assembly Bill 10034, which is looking to require parity in the standards of dental telehealth services. Senate Bill 8785, among a few others, relate to telehealth payment parity. And Senate Bill 9859 is looking to enact the Interstate Medical Licensure Compact for New York State. There are a few others, including enacting telepharmacy in New York State, as well as having the Public Service Commission review broadband and fiber optic services in New York State. Oops, sorry about that. So I am going to exit out of this now and stop sharing. I just wanted to share that update with all of you. And looks like there's a couple of questions in here. So I'm just going to open the Q&A, which has now disappeared on my screen. So give me 1 second. Yep, how can we get the presentation? Will be sent by email. Yes, we always record these sessions and send out any presenter slide decks, including what I just shared, with the master registration list. Additional upcoming webinars or events that may be of interest to this group include tomorrow, actually, NCQA is doing a task force on telehealth policy final report webinar. These webinars can be found on our website. I'm going to throw the URL for that website into the chat. So if anybody's interested, they're welcome to check that out. NCQA, for those who don't know, certainly very necessary information if you're a primary care practice doing the patient-centered medical home initiative. Additionally, later this week, Friday, the National Consortium of Telehealth Resource Centers is doing a webinar on multicultural patient engagement drives improved outcomes. And lastly, on Tuesday, September 29th at 11 a.m., the Wisconsin Hospital Association is doing a webinar on utilizing telehealth to advance rural health access. So that will be something, and I'm popping that in the chat there so that you guys can check out our website and look at these upcoming events. We also encourage you to check out our conferences website and register for the upcoming telehealth conference. You won't want to miss the state panel. That is a huge draw, and we are getting close to our registration cap, so that is certainly something you want to check out. All of the sessions that are being presented for the telehealth conference will be archived on our website after if you're not able to make all of them. So those are all the updates I have on my end. I want to thank our speakers, Tom Halsey from Haney's and Dr. Ashish from Mount Sinai for speaking today. Our next Telehealth Learning Collaborative will be in November, specifically on November 16th. And it's looking right now like we will have a team from SUNY Binghamton presenting on some of the work they've done in integrating telehealth into their nurse program curriculum, which should be very interesting. So until then, I hope to see some of you on our telehealth conference sessions next week. Feel free to reach out to me with any questions and have a wonderful day.